to introduce the panelists. We have Dr. Mercy Nyambura, Wanjiru Korir, that's what she said. But she prefers Wanjiru Korir, isn't so? Yes. She's a clinical pharmacist at the Coast General Teaching and Referral Hospital. She's a distinguished pharmacist. She has a Master of Science in Clinical Pharmacy, International Practice and Policy from London. She's currently pursuing a postgraduate diploma in Data Science and Business Analytics at the Markham School of Business University.
Good afternoon, ladies and gentlemen. My name is Dr. Wanjiru Korir. As Tabitha has graciously introduced me, I have the pleasure of doing this presentation to you. When I was requested a couple of weeks back, I actually thought heavily about not doing it, but as I kept preparing for it, it gave me more joy to imagine that I will stand here in front of my contemporaries and talk about a subject that is close to my heart. Please enjoy it together with me. This is the outline of the presentation. We are going to talk about our problem statement, drug and substance abuse, neuroscience of addiction, diagnosis, treatment, and rehabilitation, and then we look at PSK. What is a drug? I know I'm standing in front of the experts, so I better get it right, okay? A drug is any medicine, medicinal preparation, or therapeutic substance, that's according to CAP 244, that causes a change in an organism's physiology or psychology when consumed. What is a drug or substance of abuse? These are chemicals that people use to alter their mental state in a way that is not medically recommended. This can lead to addiction, dependency, and other adverse health effects. What is a psychoactive substance? A psychoactive substance is a drug or other substance that affects how the brain works and causes changes in mood, awareness, thoughts, feelings, or behavior. It is also called a psychotropic substance. What is substance abuse? Substance abuse is hazardous or addictive use of psychoactive substances with either addictive, typically depressing or stimulating or perception distorting properties. What is impulse control disorders? According to the ICD-11 diagnostic criteria, it is repeated failure to resist an impulse, urge, or drive to perform an act that is rewarding to a person. And you'll understand why I'm dwelling on the definitions. What is substance use disorders? These are medical conditions characterized by recurrent use of alcohol or other drugs, which leads to clinically and functionally significant impairment, encompassing a range of behavioral, cognitive, and psychological phenomena, presenting with a strong desire to use, difficulties in controlling use, persistence in use despite harmful consequences, assigning higher priority to use, increased tolerance, and associated acute withdrawal state upon abstinence. What are addictive and related disorders? These are chronic relapsing brain disease, state of psychological, compulsive, or physical dependence on the use of a drug or other substance, or on activities, not activities, or behaviors despite harmful consequences. Let's move on. Why are we talking about these things that I am defining? Number one, drugs and substance abuse is a major global societal problem with significant burden of disease, disability, and even death. Kenya has been mentioned as the top 13 countries of origin, departure, and transit of psychoactive substances. That is significant considering there are 196, 97 registered countries. Being number 13, there is something we are doing. According to NACADA, the prevalence of alcohol use is the highest, followed by nicotine. And please note, polysubstance abuse is not very far from alcohol and nicotine. And I will mention it as we carry on. Secondly, in the cohort of 15 to 24 years old people, they have the highest prevalence of lifetime substance abuse at 37.1%, comparable to the national prevalence of drug and substance abuse at 19.8%. You will see it when we come to the neuroscience of addiction. NACADA did a baseline report in 2016 with the support of UNODC. And in that report, more than 50% of the burden was noted to be in Mombasa, accounting to 8,000 out of the 17,000 persons who used drugs. There are many laws that govern drug abuse in the country, key of which I will consider being Cap 244, and the second one is the Narcotic Drugs and Psychotropic Substances Act number 4 of 1994, which defines the criminality around drug abuse. The substances of abuse. I'm very happy about the Menti that was done before I came to speak, because it defines a bit of what we need to know as pharmacists. Number one, there are two things we need to know. There are phytochemicals that are used as they are. Number two, they are medicines, either prescription or non-prescription things that are used as psychoactive agents. The other thing I'd like to point out is that out of all the known 900 known substances of abuse, 65% of them are stimulants. That is significant because I'm going to also tell you about the psychiatric disorders associated with drug abuse. Depressants and hallucinogens also form a component of it, but we will also have to think very clearly about the role of the pharmacist in managing the stimulants. The other thing that we need to be cognizant of is the international drug scheduling. There's Schedule 1 to 5, Schedule 1 being the most strict and restricted drugs, and Schedule 5 being the least one. I have already mentioned to you to keep an eye for multi-substance use. And why is it important for us? Because number one, people either use substances for the cumulative effect or to counter the effect. So if somebody feels very high on stimulants, they're likely to take a depressant to stabilize themselves. Maybe somebody does whatever it is they're doing, but they don't want to be known at home. So they'll go and take codeine mixed with some Sprite so that it can calm down their heart rate and then they can get back into society. But those are stories I cannot tell you now. I have many. Each one of these slides is actually a presentation on its own. Why the pharmacist? Allow me to read this one to you because it is key for you. A pharmacist, according to the Cap 244 of the laws of Kenya, a registered pharmacist is a holder. Wale watuko kwa WhatsApp, a holder of a degree in pharmacy from a university, do not quote me, from a university recognized by the board and whose name is entered in the register. Who is a specialist pharmacist? It is a registered pharmacist who has completed an approved postgraduate training program in a particular field of pharmaceutical sciences and who has gained sufficient experience. And I enjoyed the conversation in the morning about the training of specialists, who has gained sufficient experience and demonstrated to the board's satisfaction adequate knowledge and skill in his or her chosen field. Pharmacists, even as our president told us, are a preferred first point of contact by anybody in general because of their accessibility, their expertise, and their ability to intervene at various points of the medication cycle. According to the American Society of Health System Pharmacists, They said that the pharmacists have unique knowledge, skills, and responsibilities for assuming this very important role in substance use prevention, education, and assistance. The pharmacist is the best placed professional to run a drug abuse recovery program. These are the common substances of abuse. I had a list of 55. I tried to fit them in the screen, they couldn't. So I chose these ones. These are the top ones that I used, and I know you know them. If I had time, I would have asked you to tell me the names, then I'd be typing them in. I had several interviews with people to tell me. I'm taking time so that you can read. I had several interviews with people to tell me, what do you call these things? Even my housekeeper, because she lives in a place she'd know, they were telling me this thing, inaitwa sijui what, makushabu. I didn't know that makushabu is actually a substance of abuse. It is the leftovers from bangi processing. Did you know that? Now you know something new, makushabu. Anyway, I'm sure you have finished reading. Remember, when I was doing the definitions, I told you to remember that there is non-substance abuse. It is not only the drugs of abuse that give us a problem, but even non-substance abuse gives us an issue. I'm taking a bit of time so that you can read through the list and find out where you fall. Everything ranging from gambling, kleptomania, pyromania, skin picking, intermittent explosive disorders, compulsive internet use, shopping and eating, digital hoarding, etc. And please note the prevalence, 21 to 64%. Lifetime burden of disease for behavioral addiction disorders. Those are the estimates, according to a study done by MOH. What is the neuroscience of addiction? This one is a whole other presentation of itself, so allow me to just touch briefly on it. Think the physiology, the pharmacology, patterns of drug use, motivations, long-term and short-term effects, and even the predisposing factors, and they are many. But we don't have the luxury of time. Let's keep going. I will focus on two things. Number one, the hijacked reward system, that's the dopamine system. And number two, the brain circuitry changes, because these are the things that drive addiction. We all know that dopamine is the neurotransmitter for pleasure and reward. And we all know that the initial exposure to any psychotropic agencies leads to a pleasurable effect. It also gives you euphoria, and it reinforces the desire to repeat the behavior that produces that pleasure. The desensitization and tolerance is a key outcome of this behavior that actually leads to disorders that I have already described before for you. Repeated exposure to the addictive substances can lead to a decrease in dopamine sensitivity. The person needs more and more of the substance or non-substance to achieve the same level of pleasure, and this leads to tolerance, as I have said. There are two key brain parts that I'm going to mention, and it correlates with the young age I told you, 15 to 24. The nucleus accumbens has a central role in reward processing. Addiction strengthens the connections between the nucleus accumbens and other brain areas involved in motivation and memory, making it very hard to resist cravings. If you have anybody 15 to 24 in your life, just think about them, current lifestyle and choices, and what I'm telling you. The prefrontal cortex is responsible for decision making, impulse control, and planning. Addiction weakens the prefrontal cortex, making it difficult to resist urges and prioritize healthy choices. Beyond dopamine, there is glutamate and the opioid system, and I'm sure you guys know about this. The cycle of addiction gets worse with use or disuse. The initial use leads to a pleasurable experience, followed by cravings and withdrawal symptoms when the substance is not present, meaning that there is motivation for further use to relieve the negative feelings, and this perpetuates the cycle. I hope that's very clear. But there are other risk factors, including genetics, environmental factors. The reason I'm dwelling on the neuroscience is because it helps us to develop better treatment strategy that will target the underlying brain mechanisms. What are the effects of substance abuse? Think about them, both short-term and long-term, in 3 categories: physical, mental, and behavioral. And I'm sure you already know them. So I'll just pause a little bit for you to go through the list. Everything short-term, from nausea, vomiting, tremors, mood swings, anxiety, paranoia, hallucinations, increased risk-taking behavior. And in the long term, organ failure, weakened system, and that is where key populations interventions come in. There's quite a lot to talk about, including strained relationships. This is literally a slide I can dwell on for hours, but I just want to highlight it for us. Now, in the broad picture of life, what are the main effects of psychoactive substances on mental processes? I'm sure you've heard our governor articulating these effects severally in the media and even in his declarations in the last few weeks. And these are some of the things he's been talking about. What are the 4, the 5, the 7 determinants of health? What is the sociocultural impact? Safety and security, commerce, trade, and finance. I'm sure you can actually pinpoint these things as I speak about them, especially the people who consume a lot of news. And what is the political currency around the drug abuse problem? If I just finish this slide, I'll be done with the presentation, because addiction management needs a multidisciplinary approach. And the role of the pharmacist is to get into that system and see how to best apply their knowledge, their skills, and their capacity to be able to support both the team and the clients that are being served. So in the clinical teams, we have the physicians and the psychiatrists. In the clinical support teams, we have pharmacy, radiology, laboratory, and then we have the support from the social workers, psychologists, the community, law enforcement, and legal services. I have so much to say about this, including experience. I've worked with a program before that still remains close to my heart. I had promised you that I will show you the psychiatric disorders, documented and well-researched, that are associated with substance abuse. Unfortunately, in as much as this slide tried to summarize all of them, it is not possible to go through it row by row, column by column. So allow me to just tell you, anywhere you see I, it means that the onset of that psychiatric disorder is at intoxication. And anywhere you see a W, it means that it is, the onset is during withdrawal. And as you can see, many of them have both, during intoxication and during withdrawal. And these will help guide you when you're designing therapy for the people that require your help. I said before that substance abuse management approach is multi-dimensional, multi-sectoral, and multidisciplinary. We start from diagnosis. We have to think about the clinical presentation. What do you see to know what you're seeing? The laboratory, radiology, screening tools. And you also have to think, very important, the common co-infections. And it's not only the transmissible ones, but even the NCDs, because these people are rarely compliant with therapy. There's research and communications, and I'm sure if I had more time, I would add more of them. But even with these ones, in which one can you plug and get going? Of course, I read a lot to make that. Thank you very much, ladies and gentlemen.
Thank you very much, everyone. I couldn't be more honored than to stand before you all and make this presentation. I will first of all start by mentioning the UN Office on Drugs and Crime and generally contributing to the aim of the UN in maintaining global peace and security. And how we come in is through making the world safer from drugs, crime, corruption, terrorism, and other forms of organized crime. My presentation was focusing on increasing access to controlled substances while also preventing their diversion. And you'll realize that increasing access while having diversion on the other side does contribute to drug and substance use. So this is how I was able to loop in this into this presentation. And when we talk about controlled substances, we are talking about the 141 narcotic drugs that have been scheduled by international control conventions, mostly being natural substances, but also we see derivatives and synthetic drugs. A quick snapshot at the statistics, global statistics on drug use, you realize that over the last decade, the number of people using drugs has more than increased by 23%. But what is even more alarming is that now people transitioning from initial drug use into substance use disorders has almost increased by 50% during the same period of time. When you go a bit further and look at maybe the area that could be of interest to you, that is use of prescription drugs, you observe that in most other drug use patterns, when you look at through a gender perspective, if you are looking at heroin or cocaine or alcohol or tobacco and so on, you discover more men are using these drugs than women. But when it comes to prescription drugs, the rates of use between men and women is almost the same. So if you check much down there and you see non-medical use of pharmaceutical stimulants or use of pharmaceutical opioids or sedatives and tranquilizers, almost as many women use these prescription drugs as much as men. This is local data from Kenya on surveys done by the National Drug Control Authority, NACADA. So you see, as the previous speakers have mentioned, alcohol and tobacco are the most commonly used substances, but prescription drugs has come into the picture in recent years. And you realize that the people using this are mostly people between 18 and 35. And for Kenya, surprisingly, it seems like more women actually are using prescription drugs as compared to men. And comparing the likelihood of having substance use disorders, especially depressive disorder, when you compare those who use prescription drugs and those who don't use, it appears like about 5% more people who use prescription drugs are likely to develop depressive disorder. And the main ones done from this survey in Kenya, you can see antidepressants and anticholinergics being the main prescription drugs that are being used locally. So, as the world tries to control and combat the negative consequences of drugs, so historically, the world came up with these international drug control conventions. You know the three of them. The first one being the single convention on narcotic drugs. The first one being the convention on psychotropic substances of 1971. And then the last convention of 1988 that tried to intervene in terms of reducing illicit trafficking of the same substances. So these three conventions form the backbone of international drug control. And it's through this that substances are scheduled. Remember we talked about 141 substances that have been scheduled. And once a substance has been scheduled, it means it's under international control. And by the fact that our countries are signatories to these conventions means that they are internationally mandated to report and monitor the use of these substances within their jurisdictions. And scheduling decisions, it's a very interesting interaction because we have the World Health Organization producing the data related to drugs, but the actual scheduling is a political decision done through the Commission on Narcotic Drugs, where member states vote where to place a given substance in which schedule. But at the back of these international drug conventions, the backbone is actually to protect human health. So they try to limit availability, trafficking, and use of certain substances with the aim of protecting human health. But then you realize that it presents a very complex situation because some of the substances scheduled are essential medicines. And so, on one side, you are trying to minimize access or to control substances, some of which are essential medicines that are required for treatment of common ailments. So the result is that the medicines that fall under scheduled substances then also become difficult to access, especially for some countries, mostly in Africa, Central Asia, the Far East, and also South America. And we realized that these substances, especially in our region, the growing need for cancer treatment, a very heavy burden of pain related to conditions that are specific to this area. So whether it is the end stages of HIV, women who want to access reproductive health services, including cesarean section, children with severe burns and so on, who are really much in pain and need access to either morphine or other opioid-related analgesics. Mental health disorder treatment, we all know the increasing burden of mental health, especially in the African region. Neurological conditions, some of which could be congenital and so on. We also face a growing burden of opioid use disorders. People addicted to heroin and other opioids who need access to medication-assisted therapy and so on. And then some of them also used in emergency rooms and in intensive care units. But also generally healthy people who are trying to access medical services. So whether you need an operation, you are in theater, you need access to anesthesia. And so within this framework of international drug control, you see a big disparity between the developed and developing world. So if you are in the developing world, the chances that you are going to have access to these controlled substances for essential healthcare is very, very limited. And globally, we see that the statistics say that 79% of the people in the world consume less than 1% of the total morphine produced. So most of these people in Africa, South America, Central Asia, and the Far East do not just have access to these essential medications. And it's a big disparity problem. When you look at the people in high-income countries who are accounting for only 17% of the global population, they have access to 92% of the medical morphine produced in the world. So this disparity presents a very big problem. And I believe that as healthcare professionals, it's our mandate and duty to try and do what we can in order to increase access to these controlled substances for populations that need them, especially in our settings. And some of the barriers to this access have maybe been things like insufficient knowledge. And this insufficient knowledge cuts across, whether it's in the training of professionals, but also in policy formulation. So, for example, if you look at Kenya, the law that controls drugs, it's linked to having a very thin wall, a very thin line between drugs and poisons, right? So you as a practitioner, if you feel like what you are prescribing is a poison, you're gonna be very, very cautious or extremely cautious and even try to limit the levels of prescription or dispensing. And some are behavioral, just fearing that when people have access to these controlled substances, they're going to abuse them. But then also others are insufficient in the supply chain system. So supply chain systems of our country, so whether it is through KEMSA, just having inadequate checks and controls, which then limits the quota to which our countries can be allowed to import controlled substances. And those who have been in programs like the medical assisted program know very well the pain that we went through, first of all in getting methadone on the list of essential drugs and then strengthening the drug control system in order to ensure that Kenya's quota is increased to cater for the number of people who need methadone treatment. And then, because of this, then we get this other problem. Now, when you look at the side of diversion, you get the problem of non-medical use of prescription drugs. And when you talk about non-medical use, we mean taking prescription drugs. Either it's a person who has a genuine prescription for the drug, but they're using it either in a way that is not intended for the prescription, or it's someone who is using it without a prescription, or using it for other reasons, or for a different period of time, other than what the prescription meant. And while these prescription drugs are legal substances, they can still lead to severe health effects if not used in the right way. And most of them, as you've already seen, maybe could be tranquilizers, analgesics, sedatives, antidepressants, and stimulants. And we have also observed that specific groups of people are at an increased risk, especially the youth, because it seems like to the youth, because of the financial situation, just having limited purchasing power, they cannot afford the naturally occurring substances of abuse. So they resort to prescription drugs, which are much cheaper, and also resort to synthetic drugs. Women are also at a very, very high risk in all settings across the world. But then also older adults, people who are older, more than 60 years of old, who tend to really, really abuse these prescription drugs. And then also, of course, healthcare professionals. Dr. Wanjiru mentioned about the risk of engaging in use of drugs if you are a healthcare professional, maybe because of access and so on. We realized from the methadone program that some of those people who really suffered or had tried to use methadone were actually healthcare practitioners, including pharmacists. We have done some studies locally in Kenya through NACADA also to try and determine the source of these prescription drugs. And we realized that some are dispensed without prescription. And one of the participants mentioned that if I want to buy my drug, I go to a particular chemist and the chemist is going to give it to me as long as I have the money. And then others are prescriptions through family or friends, or a prescription by physicians for reasons that are not well understood. And then one patient can also go to multiple doctors and they get different prescriptions. So they'll present this to the pharmacy and buy more than what they should have bought. Others even try to falsify and forge prescriptions in order to access drugs. But also an increasing problem in illegal pharmacies selling drugs online. And one of the participants mentioned that I buy my drugs from a particular chemist. You, if you go, you will not get it. But for me, because they know me, they're going to sell it to me. And then we have also had cases of theft and burglary, where pharmacies are attacked and theft done, or maybe through diversion by the people who work in those pharmacies. And the problem with this use of non-medical use of prescription drugs is that it creates a market for them. So if there is a market in the black market for prescription drugs, people are likely to divert even more from the formal healthcare system. And if this does not meet the demand, then we are going to have illicit manufacture through clandestine laboratories, which creates even a bigger problem. So it's like a problem that snowballs out of control if not intervened early. I wanted to have these two case studies of use of prescription drugs. One is the opioid epidemic in the US, which most of us already know. And we know that in 2021 alone, about more than 100,000 people died from overdose in the US. And about 30% of these were women. And this drug overdose in the US is mostly driven by illicit fentanyl. So this is not the pharmaceutical fentanyl that we find in our hospitals. It's the one that has been made through clandestine laboratories, which has also fentanyl, but also mixed with other forms of chemicals. And this problem actually started from overprescription by physicians of fentanyl, and then later evolved to become the big problem that we are seeing now. We know very well in our setup, it started in Western Central Africa, but also moving in Eastern Africa, there is a big problem of tramadol to an extent that sometimes it becomes difficult to find tramadol within the public healthcare system for people who actually need it for the health conditions that they have. And we have observed that this problem with the tramadol has led to supply chain problems. We see from trafficking data a big consignments of tramadol from India coming here in Kenya or maybe Tanzania, repackaged and re-exported to West Africa as a product of these countries. In 2022 alone, Nigeria was able to seize over 5 tons of illicit tramadol being trafficked to that country. So, as healthcare professionals, it's a very delicate balance, but we have to try to achieve between prevention of diversion, but also increasing access to these controlled substances for people that need them. So either through your daily practice, through maybe advocacy actions, through data collection, and so on. So as I conclude, I wanted to mention that pharmacists and pharmaceutical practitioners can play a central role in supporting people with substance use disorders, because as it was mentioned earlier, within the healthcare system, pharmacists tend to be the most friendly. Yeah? So most of the first points of contact, people are likely to come to you before they even see a clinician or a medical doctor. they'll come to you first. So you could be one of the first points of contact to detect people who are suffering from substance use addiction, and maybe be able to offer them support, either refer them to treatment and so on. Within normal healthcare systems, yeah, I've already mentioned that. And then while prescription drugs are not illicit, their non-medical use can lead to serious health consequences. The lack of access to controlled substances within our setups should now be seen as a major global crisis. And we count on people like yourselves to be able to bring up these advocacy actions in order to get our governments and the national system to act, in order to increase access to controlled substances for people within our region. And then lastly, addressing diversion, non-medical use and misuse of essential drugs to ensure access and availability of people in need of these controlled substances. I also had a collection of some materials that you could refer to in this whole area of increasing access to controlled substances while preventing their diversion into illicit markets. And then lastly, our contact details in case anyone wants to make any further follow-ups on this particular area. Thank you so much.